Hey there and welcome to Concierge Medicine Radio, your source for actionable advice and real stories of physicians running and growing concierge practices. For more interviews and notes on today's show, please visit conciergemedicineradio.com and enter your email. Now, let's join your host, Taylor Pearson.
Welcome to Concierge Medicine Radio. We're joined today by Dr. Josh and Dr. Doug of Atlas MD out of Wichita, Kansas. Dr. Josh and Doug are leaders in the direct primary care movement, and they've both spoken at conferences. I heard Dr. Doug at the DPC conference in Washington, D.C. recently. They both publish an excellent newsletter and podcast, which we'll link up to for everyone to check out, about direct primary care. And that'll be in the show notes. But I want to start and have Dr. Doug and Dr. Josh talk a little bit about their practice, Atlas MD. So kind of walk us through how it's structured and how it's kind of where it fits in the DPC model.
Happy to. This is Dr. Josh and
Dr. Doug.
And again, thanks for having us on. So we both co-founded Atlas MD, Concierge Family Practice, which is ironic because we call ourselves concierge medicine, but we fall into the direct primary care category based on pricing and value. But we started September 2nd, 2010 with the idea that insurance complicates more things than it helps. We wanted to get to a high value, low cost membership model, and we set our prices $10 for kids, $50, $75, or $100 for adults through the age ranges for unlimited home visits, work visits, office visits, and technology visits. So email, webcam, cell phone, texting, Twitter, Facebook, Skype, because we can all integrate that into our software. Then no copays for anything. Any procedure we can do in the office is included free of charge. So stitches, biopsies, joint injections, EKGs, Holters, spirometry, audiometry, urinalysis, cryotherapy, DEXAs, are all included. And I'll let Dr. Doug explain the meds and labs.
So in order to further prove value, we can utilize the free market to find some very valuable medications and lab pricing for patients. And because we operate the clinic based on the membership model, we didn't feel the need to make extra money on medications or labs. So medications, for instance, we can buy wholesale, and all but just a very few states, 4 or 5 states, physicians can dispense to their own patients. And that's exactly what we do. We buy in bulk. So Prilosec, for example, I can get 1,000 Prilosec for $58. So that means I can treat someone's heartburn for about $2.50 a month versus them getting it over the counter. And a lot of times, even with good insurance, your copay is going to be more than that. So saving money there. Many other medicines are a penny a pill. Lasix is actually less than a penny a pill because 1,000 pills is $9. So I can dispense that at cost to the patient, take very good care of their health, and save money at the same time. And we've done the same thing with labs. We've worked with a local lab here in Wichita, but also just integrated Quest diagnostics into our software. So some national pricing on blood work is what we're aiming at, but a blood count that might cost somebody $30 or $40 or even more, depending on where you go, we do for less than $2. Lipid panel is $3. Thyroid panel is $4. Hemoglobin A1C for $6. So you're talking about doing yearly screening blood work for $12 to $15.
Which is fantastic. And so that's how Atlas MD fits into that direct primary care space. Is, I would say the key difference between concierge and direct primary care is typically the price. And our goal of keeping our price as low as possible and our value to our patients, our customers, as high as possible. And now it makes it very easy to sell the idea of a membership to a patient who's not familiar with that, because we can say, look how much we're saving you on unlimited visits and no copays and free procedures. But really, the objective savings for meds and labs can be multiples of their membership cost per month. So some patients make money coming to our clinic.
And we can even save them on things like CTs and ultrasounds, again, because we go to imaging providers and essentially have them bid against each other for our business. And they can build a clinic, and then we build a patient. So a CT head is $175. An MRI knee or extremity joint is $400. So we can save quite a bit there. But fundamentally, when we started Atlas MD, what we looked at was, what is it that's causing healthcare, especially primary care, to be so broken? And it's the insurance as a payer model. Physicians working more for insurance companies than for the patients. So you get back to a regular business model, and healthcare is and always has been a business. Get back to directly caring for the patient, and they pay you directly, and you take insurance out of the equation as far as a payer. But one of the things that's helped us be successful and help save patients significantly is working to find insurance plans that work.
And that might feel a little weird. A doctor's office who is singing the praises of not taking insurance is also talking about how to work with insurance. I want car insurance, home insurance, life insurance. I can only die once or twice, so I can't abuse my life insurance. But health insurance we're trying to use for everything. We're using it too much. So we want to solve both big pieces of the healthcare equation. Health care through the clinic and health insurance as well. So we find a lot of our growth comes from helping employers transition from an expensive, bloated insurance plan to a trimmed up, efficient insurance plan. It still covers everything the employees want to be covered: car wrecks, cancers, heart attacks, the scary stuff. But now you can carve out insurance for copays or labs or medicines that cost a penny a pill, because that's just an inefficient way to pay for that.
So to help make sense of what we're thinking, how we see it, imagine, for example, you use your car insurance to pay for gasoline, oil changes, and tires. Well, your premiums are going to be higher. When you go to the pump, you're not going to know what the price is because it's not listed anywhere. The person at the pump next to you is going to have a different price because they have a different plan. When you get your explanation of benefits in 2 or 3 months, you're going to see how much your insurance did or did not cover. The insurance company is going to dictate where you can get gas, what grade of fuel you can have, and if you wanted to take a trip out of town, you'd have to get a pre-authorization.
No one would stand for that. That would be you wouldn't want that plan if we tried to sell that to you. So, in a lot of ways,
why do we accept that in health insurance? So that's the thing. With direct primary care, the primary care is covered by definition. So why insure it?
And so,
and I think I was going to ask you for some examples of the high value, low cost, and you just gave me about 2 dozen. So ahead of the game there. But I was really struck. I just kind of walked around the office, and some of the things that, even having talked to a lot of other guys doing DPC or concierge, there's 1 patient room per doctor. Because of the patient load, you only need 1 room per doctor to be able to provide the kind of service. I walked in and there's a DEXA scan machine in a primary care office, which I've never seen before in my life. I think there's a surgical laser in there. So
medical laser and ultrasound and all the other testing equipment. We wanted to add as much as we could in terms of value for the patients.
And talk a little bit, because that's a totally different paradigm than's kind of ever existed, or at least in recent memories existed in medicine before this, providing this level of value to patients. So from a physician's perspective, how are you able to do that, like, economically? Just talk a little bit about how that works because of your model.
So I think the hurdle we saw before we launched was a lot of doctors, because we've been watching the space since 2000, 2001, and saw a lot of what did work and what didn't work. And so we wanted to bring the best practices into our model. And one of those was just that the cost of the membership was too high, and the things the doctor did was too low. So we can often do an autopsy of a direct care clinic that closes because of those reasons. You're not offering meds or labs or procedures for free or discounted prices, and if you charge too much for the membership, it spoils the equation. I like going to my gym, but if it costs $300 a month, I wouldn't go. And so there's a sweet spot there. So for us, we said, what all can we add that would make it easier for the patient? Well, I don't have a copay when I go to the gym, and I don't need to charge a copay in this model. the membership side's profitable enough. So I want patients to say, here's the idea that you can use as much as you want, unlimited texting, unlimited gym use for a flat, predictable rate. That gives the consumer a lot of peace of mind that if they are sick and they need it more, they don't have an unplanned hit on their budget.
And that's something that, co-pays are designed to disincentivize care. If you only get so many visits per month, some clinics have set up a model where, it's there's a monthly fee, but there's 5 visits a month. Anything more than that, there's an extra fee involved. And you have to wonder, okay, well, am I sick enough this time to use one of my 5? Well, you're going to have to decide whether you are or not, and it puts a barrier to care. Much like saying that I have unlimited text messaging versus, you could say I have 5,000 texts. I'm probably not going to send 5,000 texts a month, but I'd be thinking about it every time I do, versus saying unlimited and I just don't think about it.
And the chance of patients abusing it has essentially been zero, since we've never had to fire a patient for that. So then we just moved on. Like, what other value added could we include to increase our chance for success? So unlimited visits is nice, and then no copays is nice, and then procedures that we do in the office, probably because we never had a clinic outside of residency, we weren't stuck in that old mindset, but EKG pads cost us 3.5 cents each. Pretty sure I can absorb that as the cost of doing business. Urine dipsticks are 10 cents each. So those aren't usable things for most patients, and they're so cheap, why not throw it on?
And something I think really gets people's attention is when they have, let's say you have an infected toenail needs to come off. They'll ask us, okay, well, do you know any podiatrists that I can go to? So, well, yeah, I know several, but I can do that as well. But really, I didn't know you could do that. Oh, yeah, no, I can do that. And a lot of other procedures that people don't really realize that primary care doctors are well trained to do, but they're not used to it because their doctor never had the time to do it. And it's something that it allows physicians and practitioners to get back into the habit of being able to do the things they were trained to do and finally have the time. It's the same with treatment of chronic conditions. Some primary care doctors, you try 1 or 2 blood pressure medicines, you're still not under control, let's send you to the cardiologist. Well, there are several more classes of medicines and other things, sitting down and talking to you about your diet and your exercise and getting to the root problem and actually trying to really take care of the patient, because you do have the training, but the missing component was time.
The luxury of time. And so if I could save you $100 because I can do your joint injection or your toenail removal, why not? The model's already set to be sustainable and profitable at a higher income level just off the memberships. So everything else is just a benefit to the customer.
Well, and shopping around for the best prices and knowing that, locally we could, if we did a biopsy, we do it for free. Mm-hmm. But pathology, we're not pathologists. We need to send that off. So locally we're getting it for a little over $200, about $225. But we found a
Cole Diagnostics out of Boise, Idaho.
Yeah, so Ryan Cole, a very wonderful dermatopathologist.
Trained in Mayo.
But we can ship it off to him for less than $50. So, why would I not take advantage of something like that to save the patient? Essentially, they're being charged 4 times more for the same thing. I'm still going to have a pathologist read it, but why not save them the money?
Interesting. Henry Ford said, if A plus B equals C and C is profit, then all you have to focus on is A and B. And I think physicians have long been taught to be critical of business, assuming that good business and good medicine can't coincide. Well, in this model, all we do is we focus on A and B. If we provide really great, cost-effective care, then the profit side of it will come. So the rewarding side is, if I want EKG, I don't have to charge you $30 more. I can get it. So for my professional satisfaction of knowing I'm providing very good care, I'm removing barriers for myself as well. We can do a complete rheumatology workup for $12. That would normally be $200. Well, if I'm curious about rheumatoid conditions, I want that information, so I want to make it as easy for the patient to get that information. Why would I upcharge my medications? I want to get you to the best outcome for your migraines. So if I'm making one of the medicines unnecessarily affordable, I'm hurting myself professionally because I'm not able to get you the best outcome. So now we really take a very bold stance that the new version of doctor-patient advocacy is embracing sound business to get a better product for our customers, better health, so that if I can get your Imitrex for almost $95 less than you were paying, I am benefiting your life financially, medically, professionally. So that is, it's a combination of good medicine and good business that, I think doctors will have to, maybe wrap their head around in a new way. But the more services I can add to the clinic, the more I can do for you. The more I do for you, the more you stay. I want 600 patients who stay with me for 20 years. That will be a great medical experience in our opinion.
And you both said this more eloquently than I'll sum it up, but it's the crux of this is taking the insurers or third-party payers out of the equation, and that's what allows you to have a DEXA scan and offer all these value-added services out of a primary care facility.
Well, not only does it allow that, but for far too long, when a physician sees a patient, they document based on what insurance has dictated in order to justify the charge. So there are several levels of charges, and I won't get into the details, but several levels of charges, and then I have to have so many bullet points or so many things in my note that support what I'm doing. Well, unfortunately, as EMRs have come out, people have gotten click happy, and they'll just start clicking through the note in order to generate a higher level charge to justify what they're billing. Well, the problem is sometimes you click in the wrong place and you'll have a male that has normal adnexa. Well, that means their ovaries are normal. Hopefully he doesn't have ovaries, but unfortunately that's what the note says. So now you have a medical error or a documentation error that could potentially be a liability just because you were trying to click through the note and bill something out, whereas I can actually document only what I need to. Documentation really is only to serve for what happened, and in case I'm not around for whatever reason, other people know what happened. That's all it's for. But insurance billing right now as it stands, I've gotten 5- and 6-page notes on people for consultations that really only about half a page worth of information is really helpful. The rest of it is just fluff and bloat to justify insurance documentation.
And you'll ran through a lot of these already, but just to kind of sum up for us, what are the cornerstones, in your opinion, of the more value part of the equation?
Right. I think there's definitely a recipe here, and we don't pretend to have the best recipe, but if you're making pancakes, there's several things you must add, and there's a lot of things that you can or don't need to add, but there's certain things you shouldn't do. And so for a successful direct primary care practice, we feel that it has to be very reasonably priced and probably cheaper for children because you can do less for them, cost savings wise, but older adults have more meds, more labs, more services, so you can save them more money per month. But unlimited visits, little to no copay, as many procedures included in the membership as possible, and then the wholesale meds and labs. Does every clinic need a DEXA? No. I mean, we are fortunate to be able to provide that. An EKG and a stethoscope is probably all you really need. But if you can do the meds, then you're getting an opportunity to save not just the patient a ton of money on their health care, but also their employer. 30% of insurance premiums can be related to prescription costs. And also we can't stop all prescription costs, biologics for rheumatoid arthritis or oncology meds, but the vast majority of them we can. And so there's a lot of those things are the essentials to providing the maximum level of care at the lowest price.
So if you're a physician and you're sold on this model, you see the value, you think it's the future, what are kind of the first steps towards making that transition?
Well, there are several. I think that the first, we've helped transition now several physicians, some that are just tired of they're just tired of practicing like they've been forced to. Some are ready for outright retirement, but don't want to leave medicine. So the first thing is looking if this is something that's going to be right for you, if you want to be available to your patients and overall take better care. I know some people, a hurdle is, well, if I cut down, I have 4,000 patients and I cut down to 600, well, what happens to all those patients? I'm gonna lose some. But for some of those doctors, if you go to an employed position,
or retired.
If you retire, you lose all of them. If you go to an employed position, then your insurance, who you accept might change, and therefore you might lose some of those patients anyway. So at least with this, you have complete control of who you do or don't have as patients.
So once you've made up your mind to move into this model, I think step one would be to find an example of a doctor's office doing direct care the way that you want to do it, so that you can base your model on a successful model.
And it's been said, if you've seen one direct primary care clinic, you've seen one direct primary care clinic.
Correct. There's a lot of variation. And that's a good thing and a bad thing. I think one of the reasons the model has struggled to get traction until recently is there was a lot of doctors doing it inefficiently, but now the number of doctors doing it successfully is growing, so the traction is growing.
And we have more of a consortium of those doctors that have been successful, talking to each other and helping those that are kind of stuck or just starting out. You know, we want to help everyone. Physicians have a grand tradition of helping each other, so why would we want to compete ourselves into oblivion this early in the stage?
So good artists borrow, great artists steal. Look to borrow or steal a model from a doctor who is doing something similar. Obviously talk with them, I jest, but that way you at least have a good base to say, what all am I going to do and what is my pricing going to be? And then you talk with docs like ourselves. We offer all of our consulting for free. Map out a conversion timeline. We recommend an 8 to 12 week conversion. Less than that's just stressful on the staff because it's very quick. More than that, and it's hard to keep it on the top of mind awareness for patients. But sending out a series of 3 letters. The first one's just an introduction saying, here's why I'm changing, and we focus on the why. So tell patients the emotional side of this. I'm changing to provide better care for you. And the next 2 letters explain the model more. And then schedule a series of town halls so that you can talk with your patients, wine and cheese after hours, something, or beer and brats, as the case may be, and educate them, inform them, educate your staff, so that as those questions come up. So those are some of the first steps.
And to design pricing, you have to look at, first and foremost, what are you looking to make as income? And, being reasonable is very important. Sometimes you get stars in your eyes and say, geez, if I saw, 1,000 patient at $500 a month, then God, I'd be making millions. Well, yeah, you would, but you're probably not going to be successful and you get there. So be reasonable on an income and then figure out what your overhead is. Add those 2 things together and essentially divide by 12. The number of patients and the number of months. And you're going to get, for us, when we did it, came out to a $50 average for 600 patients. So that gave us $360,000 total income minus any overhead. And again, remember, with a lower volume clinic, your overhead is going to be lower. We have a 3-physician clinic with almost 1,600 patients, and we have 1 full-time and 1 part-time nurse, and that is our staff. So your overhead is going to be lower than what you're used to because you just have less overhead and staff.
But your profit and revenue will be higher. And so that's the equation to get to. And again, we recommend you give kids out for cheaper because that is a loss leader. It's going to bring families in and help grow your practice. I think some mistakes are overpricing kids. Well, they're sometimes more work. They sometimes are. But kids eat free at restaurants and they're cheaper prices at the movie because they're trying to bring in the family. So price it correctly is a big part.
And of course, as anyone that's run a successful business knows, having good staff is invaluable. You're going to wear more hats in a model like this, which we certainly enjoy. We answer our own phones, but you'll find that we staff RNs, but they play the role of the front office person that is talking to patients as they come in. They're helping draw labs. They're functioning as a nurse in the room with us with procedures. They're answering phone calls about what the model's all about.
And occasionally they're a therapist. Patients who come just want to talk with the nurses for a little bit because they need a friendly ear, and that's also a benefit.
And where did y'all find your staff? Because obviously that's an important part, and it's not people that have worked in perhaps the traditional system aren't going to be as well suited to work in this model?
One, we actually just hired through traditional means, and one of our nurses actually knew our most recent physician addition, Dr. Michael. So they had worked together previously, so he brought her along.
And she was looking forward to a change of pace, and the nice thing here, you're not just funneling patients through like a patient mill all day. You're actually getting to use some of your other skills elsewhere, and there's quite a bit of camaraderie, and it's an incredible amount of fun.
And we said traditional means, is that like monster.com, or you just...
Oh, I think we did a social media request for applications, and LinkedIn, and probably took 20 applications, interviewed 5 or 6 of them, and settled on.
So you found them through LinkedIn?
Mm-hmm.
You found her through LinkedIn.
Mm-hmm.
Okay.
Yeah.
And y'all touched on some of these in terms of common mistakes you've seen other people transitioning make, making sure you set reasonable pricing, hiring the right staff. What are some of the other kind of common errors?
We found that, again, dispensing medicines, and, it's possible to do repackaged medicines, but dispensing has been a barrier for some people. Having temporary staff, trying to, in order to have good staff, you're going to need to pay them well. Of course, you're going to need to incentivize them to really do everything they can to make it work. So sometimes trying to find staff from temp agencies or people that kind of come and go, your patients never really feel like they have much of a connection. Whereas, if you have staff that stay here, your patients know them, you get to know them, you get comfortable with each other.
Plus, they'll answer the phone, they'll provide the pitch and the explanation, and again, making sure that you offer a lot right off the bat. I think some docs, it's almost like selling a house. They say, well, I'll overshoot the price, and if it doesn't sell, then I'll lower the price, but if it does sell at the higher price, all the better. The problem is, we've all seen that same house that, now price lowered. You're like, well, why are they lowering the price?
And you're hoping they keep doing it. You're hoping that they just keep lowering it, and somebody's going to jump on a price much lower than they intended to sell it.
And you get one good chance to make a first impression, right? So that if your first impression is that you're expensive and unaffordable, that's what patients will remember, and you'll have to do even more work to rebrand yourself as affordable and explain why you're changing.
And part of the reason that this movement has worked, Concierge, we're all familiar with the offices that you walk in and it's got Italian marble and things shipped over from other countries to make it, gorgeous, but very expensive. And to some, that's fine. To others, it's ostentatious and is a turnoff. You need to look at your market, and in healthcare, the nice thing is your market is everyone. Mm-hmm. So you need to have, one of the things we've seen is people go a little either too high or too low in how they set up their office. So it can be a turnoff both ways, if it looks either too expensive or too cheap.
Well, we tell docs all the time, and we have a nice office. We like to think not too nice, and we have iPads in the waiting room, but that's not what makes us successful. So you can do this on a shoestring and a stethoscope, but there's a difference between looking affordable and looking cheap. And so you want to make sure that if you're starting in a small office, a great book would be the Lean Startup. You don't have to have a deck set in the beginning. They're buying you. But have that full value proposition. Have a wow factor again, and that's if they say, well, maybe I'll piecemeal it and do meds later or labs later, or I'm only going to do it 2 days a week. That makes it hard to do a successful startup.
And something else that you need to keep in mind as well. Walmart will hire any honorably discharged veteran that needs a job, whether they need the help or not. They can do that because it's a giant company and it's something they want to do. So in the beginning, of course, you're going to need to be successful. But once you're successful, you can start doing some sweat equity for patients that can't afford care or even just charity care. You can give away services, but you have to make sure that you're successful first. If you try to do too much of that too early and you don't survive, then you can't help anyone. So you definitely can do charity care in this model, and we do it. But again, you have to make sure that you're successful first.
And then one tip to be successful is the conversion. And for the docs who have the most success are the ones who do 2 or 3 months of legwork to market their practice, sell it to their existing patients, do a nice transition. So day one, they might have 200 or 300 patients already signed up. So that's what our emphasis with a lot of docs converting a practice is. There's no reason to do this and lose money. If you do this well and have it set up so you're ready to bill day one of the new model, a lot of our doctors are making more money the first month in this model than they were in the previous insurance-based model.
So let's dig into that a little more. The marketing and sales piece particularly is something I hear from a lot of physicians. That's not something they're trained to do. They're excellent physicians,
Right.
but the business side is a bit woo-woo. So you mentioned doing town halls, sending out a conversion letter. Like for the physicians you've had that day one have had 300 patients, what have they done? What are kind of the steps they've taken to get to that point?
It's really interesting because I think the best doctors to transition don't realize that they're the best doctors. They're the ones who have been doing concierge medicine in an insurance model and suffering financially for it. So they're the doctors seeing 15, 20, 25 people a day and providing great care and giving out their cell phone, but only making 100, 110, 120,000 a year. We've talked to docs making the 70 to 80,000 per year range too, but they're providing excellent care. So these docs often assume, I couldn't do direct care. That I need a DEXA, I need a gorgeous lab in a town. No, they're still buying just you. So it's that conversion of marketing, the type of care, the high touch care that they do is the key to being successful. So now you can do this with very little cost. To transition, because you're going to tell your existing patients. There's a great TED Talk for all doctors to watch. 2, 1, how to start a movement, and 2, start with why. And
Yes.
I love that one. It gave me chills with it. We have the best why of all products sold because it's patients and it's people, it's their health, it's their life. If Steve Jobs wanted to make an iPhone that made your life better, then surely a doctor can have that same passion for medicine to make your life better. So in that first letter, you share that passion. Don't do a dry, boring kind of business letter. Tell patients that you're changing because the current system won't let you take great care, that it's providing more roadblocks, it's making it expensive and distancing you from your patients. So if you share your passion for helping them, that they're going to see that and how it benefits them. Then in the next letter you can talk about the financial structure and how it all works and get into more specifics. So starting with a great first letter, almost like getting into med school, is a great step. Having a well-rounded value proposition already, again, unlimited visits, no copays, free procedures, meds and labs. Now you can start with the most wow factor right out of the gate so you get a great first impression. Most of us are probably good at talking with people because it's what we do every day. But if you're not a good public speaker, the rub in medicine is always know what you know and know what you don't. So if that's not your skill set, I would look for someone that can maybe work on commission, or that marketer, salesperson, or nurse who has a good public speaking skill set. But it's going to be relaxed, and so the other option is reach out to your colleagues. This is how we learn how to do knee injections because our attending shows us. This is how we consult and educate ourselves on all kinds of things. Business should be no different. Use those same skills, lean on your colleagues to find out how they transitioned and adapt that to your practice.
The really nice thing is the bigger direct primary care gets, the more accepted it is. Even the top branches of government are recognizing it, and it's recognized by the AAFP. Now as more than just a movement, but really as a viable practice.
More and more mainstream every day, making the transition that much easier.
Yeah, and the more patients that know that, the easier I think they will be. The first people the early adopters of this, really are kind of pioneering the way for the rest of us that, we just want to see how it goes, but we've transitioned, companies that we've helped transition into this. The employees that come in the beginning love it, and then when they go back and talk to their coworkers about how they got an appointment the same day or the care that they got, the people that didn't sign up initially started to trickle in because they saw the benefit. So the more that happens nationally, the easier it will be for physicians and patients both to get into this kind of medicine.
Yeah, I think one thing you said that I think a lot of physicians have trouble wrapping their head around is this: what their marketing really is they've been providing amazing care for their patients for the last 5 years. I think there's some stigma around marketing, especially with physicians. It's kind of like this deceptive, manipulative thing they're going in, and that's not it at all. They're providing great care, and then they're showing other people, look, I'm providing this amazing level of care, and I want to provide that to you too.
I think physicians have a real love-hate relationship with business, and for good reason. We've seen it done wrong so often.
Absolutely.
But we have better phones than have ever existed, which are helping people do all kinds of things, but because of good business. In my med school, and I'm sure like many others, they taught us to be critical of business. Maybe our best example is a physician who came in wanting to learn more, but very critical of the model because he understood it to be concierge. And when we told him, again, the value proposition, look at all that you get for $50 a month for an adult, $10 for a kid, he's like, oh, okay, so that concept of I can eat good or sleep good, I can't be proud of the profits I make because I'm making it off sick people, is a fallacy.
It'd be like a mechanic feeling bad about your car breaking down. It's just what they do.
My car breaks down regardless of the mechanic, and I'm happy he's there to fix it. So it was really interesting that within 10 minutes we could convert that doctor who was very critical to being a supporter once he understood the value. Now you're less selling and more educating. I feel great about every dollar I make because I just saved you $100 on your Prilosec. So I helped you for $50. I gave you unlimited office visits, your medicine, and now you have $50 back in your pocket. I've made your life better. I feel that's the true do no harm. I would feel worse now in a traditional model if I can save a patient $100 on their Imitrex and in our model, and then I'd go to a standard model and send them off to a pharmacy to they're $100 worse off for the wearer in a standard model. So this is actually, once physicians grasp how they're really benefiting their patients now, they can see how the standard system is harming them.
Well, and some of the things, even like email, traditionally physicians haven't emailed patients because there's no way to be reimbursed for it. But you'd be surprised at the things patients will tell you in an email about their depression or some other life events that they may be too embarrassed or shy to do so in person. So I've come to know some of my patients very well just through email because that's a much preferred means of communication for them that in a traditional practice they never would have had that opportunity or that outlet.
I think one of the words you used was education. And my background is actually marketing and sales consulting. And I like to say what I did was education-based marketing. And so I think when the service or the product you're providing is actually really high quality, you don't need to deceive people or spin it or put all this fluff on it. You're just educating them about how it works. And then when they go look at the market and see the options that are available, it's just a no-brainer, right?
Well, 90% of what we do is education. But once somebody understands what and why we're doing what we do, it sells itself.
Yeah, and actually that's a lot of our advice. People will ask, well, what's the best way to market? Well, there's a single best way, or we'd see every company do it. Radio works very well in our city. It hasn't worked well in other cities for key reasons. But the best business model that sells itself will lead to patient referrals. And that word of mouth, that transferable trust is your best avenue. But if you're selling snake oil and you know it's snake oil, then yeah, you feel really bad about it. If you're selling a great product that you really believe in, there's nothing to feel bad about. I give the exact same pitch to someone who has very little money or who has a whole lot of money. They get the exact same product. You come in, you're a guest in our home, you get the same level of care. This isn't tiered, so you may be, if you're poor, but you're a patient, you pay your bill, you get 24/7 access to me just like the very successful business person does. So in that sense, I know I'm providing great care that's the same to all people, regardless of their background.
And you need to make sure it's consistent too. Stealing from Dale Carnegie's "How to Win Friends and Influence People," there's an old saying that says, Twice I did good, and that I heard never. Once I did bad, and that I heard ever. So you need to make sure that, again, like the Starbucks experience, when you come into this office, or when you call me on the phone, or when you email me, it's going to be an experience one way or another. We can decide whether it's going to be a good experience for the patient and it's going to be something that they're going to boast about in a good way, or we can go the other direction, slip a little bit, and a little bit of bad press goes a long way, especially these days of Facebook and Twitter. If somebody has a good experience, you'd be amazed that get somebody in with a migraine and treat them quickly, and they'll boast about how they just came to the doctor with a migraine. HIPAA be darned.
Yeah.
But at the same time, if they had a bad experience, you can have quite a bit of bad response to that pretty quickly. So just making sure you're consistent in what you're doing is very helpful.
And I'll piggyback on that, because you're right, we don't want patients to have a bad experience. But at the same time, I think a lot of doctors overshoot and say, well, then am I just the whipping boy for people who've paid for membership and they can have whatever medicine they want, whether it's weight loss or ADD meds or pain meds or anxiety. No, you're still a professional. I don't know my car well enough to tell the mechanic what to do on it, but if the correct thing for him to do is to do what's best for my car, not what I think is right for my car. So if a patient wants antibiotics, I'd rather them be upset and leave than practice bad medicine. So, my degree, my professional integrity is not for sale. I'll find 600 people to fill the clinic who want my style of medicine. And so in that way, it's a lot nicer than the standard model where docs are really falling victim to the Press-Ganey scores and how that affects their reimbursement, and bean counters are demanding that they do a little bit more pain meds or a little bit more antibiotics to keep people happy. We practice great medicine, but we have the luxury of time to explain to patients why we're not giving them antibiotics, or help them lose weight, or work through their anxiety with other meds. So you don't want a bad experience, but at the same time, you have the luxury of protecting your integrity now more in this model than standard model.
Yeah, the phrase that comes to mind for me is trusted advisor.
Yeah.
And I think with people I worked in the past, that's always kind of the role I try and put myself in. Is like, I want to be the trusted advisor. And sometimes that's like tough love, right?
Yeah.
It's like, I want the best outcomes for you. So how do we get those? And sometimes that means saying the things that they don't necessarily want to hear.
Well, just like being a good parent, parents can't always be their children's friend. At some point, you're going to have to, be the adult in the situation. And it's same with your physician. I mean, I have a good reputation and rapport with my patients, but there are times that, if you need to be stern about something, talking about their weight or diabetes or blood pressure, I can't always just say nice things if what I need to get accomplished means that, I just need to be honest. You need to trust that I'm doing it for your best interest, not just to keep you a friend.
And it's great that you say that, because trust is such a huge part of how we describe this usually. There's a wonderful book, Speed of Trust by Steve Covey. And healthcare is a low-trust industry. And unfortunately, patients don't trust their doctors as much as they should because of the influence of insurance. So, we hear it all the time when we work the ER. My doctor does or does not do something because he does or does not get paid. It doesn't have to be logical when it's an assumption. So when they feel like they've been shorted on their care, they're quick to assume that the doctor did something malaligned. So that's one reason we encourage docs to offer unlimited visits or no copays or free procedure. I'm not doing a procedure because I make money off it. I'm doing it, and I'm not doing it. I'm not avoiding it because I don't get to charge you. It's just, what do you need? I'm not upping the cost of cholesterol medicine to perpetuate some myth that from the pharmaceutical companies. It's because I think you need it, and so I'm going to give it to you at my price, so you know that this is a very maximally trustful relationship.
Well, in this day and age, it's difficult enough as a physician even to stay up to date with recommendations, because different societies or organizations will have contradictory recommendations. But there hasn't been this much snake oil in society since the late 1800s. I mean, look at Dr. Oz just recently, promoting things that have very little, if any, scientific data to support them. But there are things out there that people think are good for them. Vaccines are bad for various reasons. Well, they're really not, and scientifically we know that. So being able to trust your physician and have a relationship with somebody that you know is working in your best interest, not their own, for financial or other reasons, is absolutely paramount to bringing the profession back to what it used to be, and somewhat still is, but I think we have a ways to go to get back to our patients truly trusting what we're doing for them.
I've already jotted down a couple of books y'all mentioned: The Starbucks Experience, Speed of Trust, How to Win Friends and Influence People, which is one of my favorites. Are there any other books you'd recommend or resources you'd recommend?
9.5 Things You Would Do Different If Disney Ran Your Hospital. Okay. Excellent book. Blue Ocean Strategy.
Getting to Why?
Getting to Yes.
Or Getting to Yes, I'm sorry.
Start with Why. That's a fantastic one. We have a shared Audible account, so we can listen to business books. So we have a bunch of those. But yeah, and I would encourage docs to do that a lot. But the Checklist Manifesto, David and Goliath, Start with Why, Leaders Eat Last.
Okay, and we'll put a link to all these on the interview when they go live. Walk us through the story of the physician that gave you a call a couple years ago, what his situation was and what happened.
Yeah, Dr. John and Harry Isbicki out of Erie, Pennsylvania, had a great story. I think a real standard example of physicians struggling in an insurance model, and then their success story converting to direct primary care. But he said, look, we're having a very difficult time financially, and we think insurance will run us out of business within a year. And this was a year ago this June. He said, I feel like I'm failing as a physician, a husband, and a father. And I said, man, that's everything. That's why physicians have the highest level of depression and suicide. So we got them to convert, and they did a 3-month conversion. They did a fantastic job, had a huge response, 400 plus enrollees day one to their practice, and have grown since. So, and now to the point of able to take vacations and a year, 9 months into it, they're again probably one of our best success stories. So for physicians to be able to see an example of, that kind of fits my story. I'm struggling financially. I'm not happy in this practice. I don't feel like medicine is going to be a long-term job for me because the stress is so high. Can see how well it can work when it comes over. And they didn't do anything special. They didn't have venture capitalist money. They're your regular guys doing a regular clinic and for regular people, and they were able to make it be successful very easily. And so if they can do it, and they've told other doctors how to do it, and just every direct primary care physician in the space is, I think, so happy to find success and professional satisfaction that they're willing to share that with other providers who are going through the same thing.
I'll let you riff on this real quick while I flip the mic back on here, but we were talking about one of the criticisms this model gets is what's going to happen with the physician shortage.
So depending on the study, they say that we're going to have a physician shortage of 50 to 100,000 providers in the next several years. Well, and everyone understandably is concerned that direct primary care will worsen the physician shortage because, yes, each doctor is seeing fewer patients. Our response is, no, the current model led to the physician shortage. I mean, driving doctors out of practice and making them inefficient is what is causing this problem. So, but in reality, we don't have a physician shortage. We have an efficiency issue. There was a study published last year that said 22% of a physician's time is spent doing insurance paperwork. And if you're just spending 22% of the time, you're doing pretty good. But they said 22% of that time multiplied across the physician workforce would be like adding 165,000 physicians back into the workforce, upwards of triple what the shortage is projected to be. And so it really is an idea that direct primary care is going to make us significantly more efficient, but also is going to restore the passion to medicine again. It's going to keep older doctors from retiring, which means we could get 10, 15, 20 more years of care from those experienced physicians. It'll get other doctors back into either full-time medicine or away from specialists because that's not their only option, or hospital or ER or locums work. They can be satisfied in a standard practice like this, and just encourage medical students and residents to focus on primary care. So we really see direct primary care as the only solution. The current ship is sinking, that we know, and it will just keep sinking. Direct primary care is probably the only ship coming along that could do something other than sink. So
I think part of what gets me excited about this is it's a paradigm shift both from the business perspective and the care perspective, and that it's looking at root causes, right? Yeah. So the from the care perspective, if someone comes in and they're overweight and they have high cholesterol and high blood pressure, in the traditional model, what happens? You give them a blood pressure med, you put them on a statin, and you say good luck because you've got 6 minutes.
Right.
Whereas, you're talking about, y'all have a DEXA scheme. You've brought people in to do DEXA scans. You're tracking their, diet and weight loss programs, adding muscle, reducing fat. And so she's not going to need a cholesterol medicine. She's not going to need blood pressure medicine because the root cause is going to be addressed. So,
well, and it's flat pricing. So if she needs an hour, she gets an hour.
Right.
And because you have a lot of issues, let's take the time to talk about them in one sitting efficiently, rather than 7 minutes at a time and letting you get lost in the system.
But the same is true from the business perspective side of it. So it's if you're looking at it from the perspective of a resident or even a college student, right? You're going to spend all this time in education, and you're going to be a family physician. I actually have a friend who's in his third year of medical school right now, and he's between family medicine and cardiology.
Sure.
And one of the big arguments he has against family medicine is just economically,
right.
It's going to be really tough, right? It's like he's got all this student loan debt, and he's got to come out, and how is he going to pay this doing family medicine in the traditional model?
Right.
And all of a sudden, DPC is like, this is how you're going to pay that.
We're all smart people. We know we have an economic expense in this. Might as well maximize my economic possibilities and go to a special. If I'm going to work hard no matter what I do, I might as well get paid as well as I can for working that hard. And obviously they see family physicians, primary care as kind of the unappreciated stepchild of the medical system, because we just keep seeing 40, 50, 60 people a day. Our reimbursement is the lowest per patient. We see the most patients. And so this is a solution that really does fix that. Now you're not being paid for quantity, you're being paid for quality. While in a very unique way, making it cheaper for the patient. And so this is a win-win for patients, physicians, employers, and even insurance companies, and ultimately the government.
And I want to kind of shift gears a little bit here and talk about technology and where you see technology going and the role it's going to play in primary care specifically and kind of medicine in general, and then also talk a little bit about your software and what y'all are working on with that.
Yeah, we were speaking about this before we get started, and it's definitely a passion point for us. Very exciting now that we've removed the healthcare model away from the payment model of insurance. So there's not a delay in getting new features, new services into a doctor's mix. So MIT is doing research on scanning social media for signs of suicidal thoughts or depression. Awesome. I don't care what the insurance reimbursement is on that. I want that code. I want to pay for that code. I want to insert it into my EMR because we already have our patients' Facebook and Twitter accounts linked into there. So now my EMR is looking for signs of depression in patients and maybe even suicidal thoughts without me having to do it. Looking for that quiet call for help. Or now there's a plethora of blood pressure cuffs and pedometers and wireless scales and glucometers that sync with your phone. I want all of that new digital data to integrate with our chart. That's me helping you provide better care. That's exciting. If your corporate, if your employer wants a corporate wellness program and wants everyone to walk 5,000 steps per day, we can facilitate that. You add in some game theory. I would be more than happy to give our patients a discounted rate per month if they check their blood pressure, once a day and they walked 5,000 steps and they took their med. Yeah, absolutely. If I'm getting to healthier patients, that's easier work for me. It's better results. I'm more than happy and able to take less income for that. So there's just a whole new horizon out there that we're just, I think, coming upon as the technology gets better, and Apple's Health Book and Google has a similar product. I don't want to say snubbing the nose at HIPAA, but identifying HIPAA for what it is good at and not good at. It's a barrier, not a benefit. People are more comfortable sharing their data now than ever. They want that. They're demanding that. And as such, we should as a market, comply with that. So young, healthy people who are checking their blood pressure and watching their activity level and getting their labs, they want to share that data just like they would share financial data. We could have 1,000 congestive heart failure patients weighing on 1,000 scales every day and only seeing the 20 who are going to have an exacerbation and go to the hospital in 3 days. Well, that's the third most expensive hospitalization. So at $30,000 a pop, if we prevent even a few of those, we're doing amazing things. So that side, we built our own EMR to help doctors who are doing insurance-free practices and does all these things. That's why it's so exciting.
And this is a thought experiment I've run before, and there's not a right answer to it. But what is the day-to-day life of a physician going to be like in 5 or 10 years when we've got all these tools?
I think it will be still a lot of work. I mean, I don't want it to be so rosy-colored, say it won't be work. Any successful job is work, but it'll be efficient work. It'll be meaningful work. So they say anywhere from 22 to 45% of a physician's time is spent on non-clinical paperwork, insurance forms, etc. That's what sucks the life out of doctors. But if I can have my futuristic Google Glass on, or my tablet, or showing me patient data, the blood pressure's high, medication compliance is down, I can text message a patient that you need to increase your evening dose of this medicine, or congratulations, you and your kid have walked 10,000 steps each day for the last few days, and look at your weight, it's come down. So it'll be a very integrated experience, but now a much more fulfilling experience, because everything that the physician is doing is focused on care and less about insurance and paperwork and forms and ICD-9 and coding. I haven't coded anything in 3.5 years, and I love it, because that's not a benefit to our patients in the grand scheme. So even though some we see 600 patients and some will see 700 or 800 or 900, there'll be shifts and fluctuations and variations on the model. The key points of a simple payment system that smooths out those complexities in this ever growing but ever sophisticated integration of technology and data. I joke that doctors are or should be data whores. I can't do anything if I don't know what your blood pressures are. But the research shows if I'd manage your blood pressure well over 10 years, I'd decrease your stroke risk by 80%. So we may never have strokes again if I can just get patients to check their blood pressure once a day on a regular basis. So now the technology has never been so health-focused and so advanced, and now the business model is adapting to that. So we'll quite literally be able to move at the speed of technology, if not slightly faster.
From a patient perspective, that's what's exciting to do about me. It's like it's easier and easier for me to track all this data about myself, and I even opened this app on my iPhone and I realized it was tracking how many steps I was walking. I didn't even know the app did that, and I was just like, oh, I walked 6,000 steps yesterday, right? But it's, as a patient, as someone that doesn't have either the knowledge base or the experience, I have all this data about myself. I've got blood work I've done every 6 months for the past 3 years. I have no idea what to do about it, right? It's like I know where I want to go, and I have all this data about where I am now, and I need someone to help me get there.
I think most doctors aren't good with their finances, or legal stuff or accounting things. So those are great examples to kind of put ourselves into a patient's experience of being the uninformed person in the room. And so, I've got, until I put everything into Mint, the financial app for my investments, I knew I had investments. I didn't know what they were doing or where they were at, and I knew I had a lot of debt, but I didn't again. But now I can pull it up, any time I want and see where am I at, what's growing, what's shrinking, what are my student loans, and I can take that to my financial advisor and say, are we on track? Now I've got the data, and I can work with the people who have the experience to interpret the data. That is the great equalizer in healthcare.
And tell us a little bit, you're working on some software here that you're building out to run your practice.
Yes.
Tell us a little bit about that, how it works. Educate us.
We started, when we started, we had 9 different software platforms open for the business of running the business. QuickBooks for billing, Practice Fusion for free medical charts, Outlook for scheduling, Outlook for emails, my phone for text messages, Twitter, Stamps.com for postage, a shared file on the server for faxes, another online source, MD Scripts for the pharmaceutical inventory, Dymo for the custom label printing. It was just a very complicated, inefficient system, and it was sinking the ship. It was going to affect the overall rate that we could grow, or even if we could be sustainable. So it was 6 months in that Doug and I looked at each other and said, if we brought in another physician, we would have to show them 8 or 9 different places to get data, or 6 or 7 different passwords, and none of it was mobile, none of it integrated. We'd need extra staff for the inefficiencies. So we started building our own, just again out of necessity. And feature creep has probably been the buzzword for all of this. You get a calendar feature, great. Now, can we click to drag? Can we, if we can schedule them, can we text message them about the appointment? If we can text message them, can we email them? And can we, do other things in that model? And if I can, anything that I see as digital data, can I integrate that in? So I want to be able to track their email so that I don't have to double chart the email conversations, and I want that to be effortless. I want it to be mobile, and I want it to run across the smartphones, tablets, and desktops, and I want it to be web-based so it's always live and I can never lose it. And then we just keep adding more features, whether it's security features or lab integration or inventory or billing. So now, again, for us to be able to run a 3-physician practice with 1.5 staff, we're more efficient with 1,600 patients than we were at 300 patients, because it is just all right there. The invoices automatically happen instead of my wife spending 40 hours of prep work before the end of the month to make invoices happen. Labs, when they're ordered, that price just drops into their invoice. And if they're part of an employer group, that math just gets divided up the way that employer's asked for it to be done. So anything that's repetitive, we can kind of program a smooth process for. So that's been a lot of fun, because now it just opens up the doors to whatever we need or whatever other physicians need. So our EMR, Atlas MD EMR, is built, I think, uniquely for physicians doing an insurance-free model. A lot of fun.
Awesome. Well, where can people get in touch with you if they have more questions or want to learn more? What's the best way?
Call, text, email, Twitter, Facebook. I think we're the most successful physicians I know, because we will just respond to any doctor or patient response inquiry, because we're so passionate about the model. Our EMR is atlas.md for no.com. That's the sales site, but our clinic site is atlas.md/Wichita. Then you can email us at hello@atlas.md, Twitter atlasmd, facebook.com/atlasmd, and then you can even call my cell, 316-734-8096, because any physician who's even thinking about exploring this, we know they just want to keep the tires first, and they'll never get to steps 2, 3, and 4. They don't get past step 1. So I think step 1 is learn about it from someone doing it, get past the misconceptions, and learn how it really could work for themselves and their patients.
And we'll link up to all that stuff on the site, so you can y'all can find it easily. And I would definitely recommend Dr. Josh. I just sent him an email last week, like, hey, I'm going to be in Wichita. Can I come check out the office? Sure, come by. So super welcome and super friendly. So thanks for joining us today.
Absolutely.
And appreciate your time.
Thank you. It was a pleasure.
Hey guys, this is your host, Taylor Pearson. To give you a little background on the show, after seeing my dad and sister, both physicians, struggle to find a good resource for how to transition from their traditional practices, I launched Concierge Medicine Radio to create a resource to help physicians and healthcare professionals launch, run, and grow patient-centered direct pay or concierge practices. If you enjoy the show and want to help us spread the word to other physicians and healthcare professionals, it really helps us out if you'll leave a review on iTunes. I know the iTunes interface is a little clunky to say the least, so we put together a quick guide on how you can leave us a review at conciergemedicineradio.com/review, or you can go to conciergemedicineradio.com and click Spread the Word.
Thanks for joining us today at Concierge Medicine Radio. If you found today's show valuable, we'd love it if you spread the word by leaving us a review on iTunes or sharing it with your friends. To see notes on today's show, please visit us at conciergemedicineradio.com. While you're there, leave us your email to hear about all upcoming episodes.